Is that how I go? Okay. How many of you know about prune belly syndrome? Okay. So I'm going to start by, Dr. Tan was talking about the importance of the bladder. So I'm going to talk a little bit about bladder function, urinary tract infections, and then more specifically about prune belly syndrome. So these are the, let's see, so you can see the kidneys there, and the kidneys are attached to the ureter, and the ureter travels down to the bladder. So it's supposed to be a one-way street. And the reason is there's normally a valve, we call it a flap valve, between where the ureter attaches to the bladder. Now, the urinary tract is lined with smooth muscle all the way from not only the blood vessels, of course, but also with the inside of the urinary tract, the renal pelvis. The ureter is normally lined with smooth muscle. Do you all know what smooth muscle is versus skeletal? Okay, so it's lined with smooth muscle, and so it creates normal, it's supposed to create normal peristalsis or pushing the urine down. And then, of course, the bladder is lined with muscle here. You can see these little muscle fibers, and that's smooth muscle. So the ureter comes in at an angle normally. When you urinate, this is just showing the bladder here, and this is the sphincter, so the external sphincter. So normally when an individual goes to the bathroom, when they urinate, they relax their pelvic floor muscles. It's not that conscious, but you're just sort of relaxing your pelvic floor, and then the bladder is supposed to just automatically push the urine out. So this is just showing on the left, normally as the bladder is filling, the bladder is supposed to relax, and it's supposed to store urine. And as it gets more and more full, the sphincter muscles start to close. And then when you urinate, it's the reverse. So it's the parasympathetic and sympathetic systems that work in opposite ways. So I want to talk a little bit about UTIs, just so we're on the same page. So UTI means is urinary infection. It can be either a bladder infection or a kidney infection. So sometimes you go to the emergency room, they say you may have pyelonephritis. They say, well, you just have a UTI. And so so UTI is the umbrella term. And so a bladder infection is the other term for it is cystitis. And these are ascending infections. So they come from the outside. So in women, it comes from the vaginal flora that may have E. coli or some other urinary pathogen. And then in boys, it comes from all the way from the outside of the urethra all the way in. It's possible that there could be a foreign body in the urethra or in the urinary tract that's causing it, but typically it's what we call an ascending infection, meaning it's going up. It doesn't come through the bloodstream. Now, another form of UTI is pyelonephritis or a kidney infection. So in these cases, the bacteria enter the bladder, but then they have to go up all the way up into the kidney. And so with cystitis, there's suprapubic pain, smelly urine, painful urination. With a kidney infection, you almost always have a fever. You really get sick. So with a bladder infection, if you have 3 or 4 bladder infections, it's not going to cause harm to your bladder or to your kidneys. But as Dr. Tan showed, if you have repeated kidney infections, it can cause damage or scarring. So we take the children who have kidney infections very seriously. And there are a number of different factors that can make it more likely to make them prone to it. One is having a dilated urinary tract, having hydronephrosis, or it may be that the bladder isn't emptying well, or they may have urinary reflux. So these are all predisposing conditions that we take into account, and sometimes these need to be corrected surgically. Now, prune belly syndrome is also called Eagle-Barrett syndrome, or it's called the triad syndrome. So the classic appearance is that there is a big swollen bladder, hydronephrosis. There may be dysplasia. So if a kidney, if it's sometimes as it just forms no normal glomeruli or normal kidney working units, and that's called dysplasia. And typically they're very dilated, tortuous ureters connected to the bladder. They typically have abdominal testicles, and then the abdominal muscles are very poorly developed. Interestingly, almost all of these individuals are boys. If in girls with this, they're more severely affected. And of the MSMDS cases, 17% are affected with Prune belly syndrome. So these are typical appearances in neonates with this. So you can see a floppy. This is what. Go back. So the abdomen here is just it's just very flimsy and soft. This is it's typically very wrinkled. And what's interesting is you can palpate all of the organs in these babies. You can feel the liver, the spleen, the kidneys, just because everything is so soft. The muscles here are just very, very poorly developed typically. And then there are a number of other issues that can occur. The bladder is typically very distended, and here this is just showing. This is what's called an IVP, which is not really done very much anymore, but it's just showing the appearance of the upper tracts here. But they're very tortuous ureters, and you can see here this is even more severe, and the bladder is sort of faintly, if you can see my pointer here, is sort of faintly showing, but you can see just how tortuous these are. Why are they tortuous? Well, the ureters are in a sheath. There's sort of a, not a muscular sheath, but there's just sort of a sheath around them. And so as they, if they're obstructed or if they're too wide, they just become very tortuous. So, they're just massively enlarged urinary tracts, typically, very large bladder. They may have a urachal diverticulum, which I'll show you. The urachus is the embryologic connection of the bladder to the umbilicus. So sometimes there's poor formation of the urethra, so they can't really urinate. But in utero, the connection between the bladder and the umbilicus may remain open, and that can save their bladders and urinary function. The bladder is sort of thickened, but the muscle isn't very well developed. So there's no definite obstruction, but there's much more collagen. It's more fibrotic, if you will. So because of there's an incomplete muscles, it doesn't contract or empty as well. They may have a significant, they often will have a significant residual urine. They may carry a lot of, so even in the newborn, we're trying to figure out how are we going to drain their kidneys? Are we just going to let their bladder remain very dilated and have them empty intermittently, or do we need to drain them with the vesicostomy? But in the long run, about 50% of these patients urinate spontaneously, and their voiding pressures are normal. This is so this is just showing the bladder. There's urinary backflow into the kidney. So normally this is a voiding cystourethrogram where the bladder is filled with contrast. And normally when you urinate, all the urine will come out through the urethra. But in in children with Prune belly syndrome, often they'll have reflux. And this is a urachal diverticulum. So this is in this image, it's very large. So if the bladder is trying to empty, some of the urine's going into this pocket here. So that can result in incomplete emptying. And with all this retained urine, it increases the risk of infection. There are many associated anomalies. The respiratory tract can be affected. So, why does Prune belly syndrome occur? We don't really know the cause. We know that it occurs about 1 in 40,000, but experimentally in the 80s, there was a sheep study that where they in a fetal sheep model, they created nearly a complete obstruction of the urethra for a short time in the first trimester of the sheep, and then released it during the second trimester. So it created a large backup of urine into the kidneys and into the bladder, but yet there was no definite obstruction when the sheep were born. So it's thought that there might be some similar cause for that in humans with Prune belly syndrome, but many have a number of other associated issues with the GI tract, cardiac, and musculoskeletal. There are three basic. This was proposed a number of years ago, so we sort of go with this 3 categories. So the most severe is category 1, where they have poorly functioning kidneys. As you probably know, the amniotic fluid comes from the urine. So if there's a very poor renal function, or if there's an obstruction of the urinary tract, there's going to be significantly reduced amniotic fluid. The amniotic fluid stimulates the lungs to grow and develop. So if you don't have enough amniotic fluid, the lungs aren't going to be developing. So when they're born, they won't be able to be sustained even with a respirator. And there can be a urethral atresia. That's the worst. The second is they have the classic features but the kidneys are functioning reasonably. There's no pulmonary effect, but they may progress to renal failure, particularly if the management isn't optimal. And then the third category is really they're mild triad features. They have part of the urinary tract is abnormal, but the kidneys are doing well and they have stable renal function with no pulmonary hypoplasia. This is a picture. This is an intraoperative picture. So this is showing the bladder. These are the ureters. I mean, they're just enormous in size, and you can see these testicles are basically attached or stuck to the big wide ureters, and then there's a very large sigmoid colon. So they often will have constipation, and so the colon gets backed up and the bladder's backed up, and it really takes a lot of intense management. Management of these patients is a team effort. It's not, and fortunately in Mass General, we have a great team that's working to keep to try and optimize the health of these patients. So we have nephrology here, GI, cardiac, genetics, orthopedic surgery, radiology, anesthesia. And then the other one, which is fairly new, is what's called transitional care. So some of these patients, when they're going to become adults, and so there are some centers where they say, okay, you're 18 or 20, go find somebody else. And there are really very, very few adult urologists who are interested in taking care of older patients with, adult patients with congenital urinary anomalies. So I think at least in our section, we take it on ourselves to continue following these patients. And if they need referral for an adult kidney stone, or infertility, or erectile dysfunction, or something that needs to be managed by an adult person, that's fine. But we tend to try and continue coordinating their care. So bladder management, the goal is to try and avoid UTI. One of the best ways to prevent a UTI is by doing a circumcision. So in boys who are normal, no hydronephrosis, no urinary reflux, boys who are uncircumcised are 10 times more likely to get a kidney infection. So in the first year, that means many of them end up in the hospital. Now, I'm not a circumcision advocate. I'm not pro-circumcision. I'm not anti-circumcision. But if they have a urinary tract abnormality, I try and I think it's worthwhile if it's an option. Some may need antibiotic prophylaxis to prevent infection. So That's but in the newborn with prune belly syndrome, again, we're trying to evaluate the kidneys, determine are they going to function reasonably well, or do they have a lot of retained urine, and clean intermittent catheterization, by inserting a catheter intermittently, a Foley catheter, subpubic tube, a Mitrofanoff, or possibly a what we call a button. So I don't know how much you know about the urinary catheters and everything. So this is what's called a Foley catheter. So you can see there's a balloon in there. So you fill the balloon from the end here, and you usually put about 3 to 5 cc's in this balloon. And so that's what holds it inside the bladder, and then just drains out continually into a bag. So that can work okay. It can, you have to be careful, because when you're draining the bag, it can allow bacteria in. So in fact, in hospitals now, for many general surgery cases, they leave, in orthopedics, they leave a catheter in during the surgery, and they leave it in for a few days. But there's really an effort to really get the catheter out as soon as possible. And that's one of the metrics that many hospitals use to compare each other. Let's see. Okay, so then you can do a suprapubic tube. So this is a similar type of, like a balloon catheter, and then it's inserted, so it just drains the bladder continually. So that's actually easier. You're less likely to. These can be changed pretty readily. Once this has been in for about 4 weeks, you can, if it comes out, you can reinsert the catheter through that opening. And that often we put these in percutaneously, so we don't have to make a big incision to get that in. There's what's called a Dawson-Mueller catheter. This is inserted by interventional radiology. Dawson, this was developed at Mass General, and it's really a good catheter. There's a little loop here, and there's a suture there that tries to keep it in, and they come in different sizes. So drains pretty well, and it's extremely uncommon. So if you have a catheter in the bladder, it can develop stones and crystals on it. But it's very, very rare with the Dawson-Mueller to get stones. There's a surgical procedure called a Mitrofanoff. What we do, this has been around for about 30 years or more. We can use the appendix. So the appendix is at the very beginning of the large intestine, and it has its own blood supply. So we can take it off the cecum and transfer it, open this end here, and then implant it into the bladder in such a way that it doesn't leak. And often we'll bring this out through the umbilicus. And so that's a way to allow intermittent catheterization for the bladder. And I've done this in a few patients with prune belly syndrome. It works, and it's worked out well. We have one of the newer things is called a vesicostomy button. So this is this is the opening, and there's a little balloon in there. This is actually used as a gastrostomy tube for feeding. So this has been used in the bladder for over a decade in selected patients. So this is a connector, and you can use that to drain. In our office over in the hospital, there's this little doll. So this is the little doll to teach how to do a gastrostomy tube. So, but you can sort of learn how to remove it and insert it. So it's even have an official diaper there with poop on it. Fake poop, by the way. And then this is the patient care kit that comes with it. So you can see, you can irrigate it, you can attach it, you can drain the bladder, you can use this syringe to infuse in and out. Some of these patients who are getting drained, one of the ways, in addition to oral antibiotic prophylaxis, is to infuse a gentamicin solution a strong antibiotic solution into the bladder intermittently to try and prevent infection. So this is a newer way of doing it. This is a paper published a few years ago. These are not patients with Prune belly syndrome. They're neurogenic bladder, severe abnormal bladder, and 3 with urethral valves, which is something similar to Prune belly syndrome. So the median age was 3.8 years. The youngest was 7 months. They were using an 18 French, which is pretty large. If you have a drainage catheter, the larger it is, the faster it drains. So if you're, if you have a newborn with a neurogenic bladder and you're inserting an 8 French feeding tube into the bladder to drain it, it may take 5 or 10 minutes for a large bladder to drain. It's a long time. So the larger catheter you can get in, the faster it's going to drain. So anyway, if you had button malfunction, you can put it into the vesicostomy. So if you have a vesicostomy, meaning an opening where they've created a bladder opening to the skin, you can actually just put it right into the vesicostomy. They did not find that with this treatment that there was a reduction in the number of urinary infections, however. So, but again, it's a more efficient way of draining the bladder. And that's what I have. So I hope you have a better understanding of some of the problems that these children have. Thank you.